Hi, my name is Alessandra Dornty. This is the video presentation of case study number 2 for the Department of Nursing at West Texas A&M for the class Primary Healthcare Clinical 3, Nursing 6443. So we are starting with the subjective data. We have a 35-year-old Hispanic female with the initials YR. She initially presented to the clinic on March 28th with symptoms of anxiety and depression, complaining of mood swings. She was a new patient to the clinic. She was not established with us, and she consented verbally to the use of her information in this case study. So her chief complaint was weight gain and mood disturbances. She was complaining of feeling anxious, unable to sleep, loss of pleasure doing her daily activities, loss of interest in her hobbies. She also complained of a irregular menstrual cycle and heavy periods, but she also let us know in her history. So then moving on to history of present illness. She recently had 2 premature births with fetal demise at between 20 and 30 weeks. And both were in the span of the past year. So this is what she verbally said that she attributed most of her anxiety and depression type symptoms to be from, but she wanted to have some help dealing with these symptoms. So as I said, she was complaining of fatigue, anxiety, significant weight gain, the irregular menses. She was experiencing difficulty concentrating along with feelings of stress. Even though she was reporting all these feelings of anxiety and depression, she denied any suicidal ideations. And she did report that she has good support at home. She is married, has been married for the past 5 years. She says she has good support at home. But her symptoms have been affecting her daily functioning. So her past medical and surgical history, she had a lap appy in 2011 and then a cesarean section for her one child in 2014. Medically, she was previously on an anxiety medication. She was taking sertraline 100 milligrams previously, but she came in saying that that was no longer controlling her anxiety and depression. And then as far as her OBGYN history, she has 1 living child delivered by the cesarean section in 2014, and then the history of the 2 premature births within the past year, both resulting in fetal demise. She had no other past medical history that she reported. She reported no family history that she knew of. She said her parents were both generally healthy individuals. As far as her social history, as I said, she is married. She lives with her spouse in a home that they own with her child. She is regularly employed. She works in the school system. She reports no alcohol, no tobacco, and no illicit substance use. She does have private insurance, and her social support, she reports to be adequate. As far as her current medications, allergies, and immunizations, she does take a yearly flu shot. Her COVID vaccinations are up to date. She reports that she believes she got all of her childhood immunizations. She has no known drug allergies. She said nothing that she knew of. And then the only prescription medication she took was sertraline 100 milligrams. Otherwise, she said she was taking a vitamin. She was taking like a prenatal multivitamin daily, and that was her only other medication that she took. As far as the subjective review of systems, she complained of generalized fatigue and the weight gain. In the endocrine, in the reproductive area, the irregular menstrual cycles, the menorrhagia, and the history of premature births. As far as the psychiatric system, anxiety, depression, mood swings, difficulty concentrating, feelings of sadness and hopelessness, insomnia, anhedonia, but she denies suicidal ideations. And then she denied any complaints in all other systems. She denied any respiratory complaints, any cardiac complaints, no musculoskeletal complaints. She didn't complain of any like aches or pains or anything. No GI concerns and no other like head, eyes, ears, hint type symptoms that she reported. For our objective data, starting with her vital signs, she is a 5'6" female. She weighs 92.9 kilograms, which makes her BMI 33.1, which is classified as obese. Her temperature was 97.0. Her blood pressure was 118/70, heart rate 99 beats a minute, and then her oxygen saturation was 99% on room air. With her general appearance, just walking in the room, she was very tearful. She appeared tired. She was well nourished. She was well developed, and she did appear like clean and well put together. But she just looked like she felt tired, like she was not enjoying being in the office. Um, she had a kind of a flat affect and then tearful at times. And then going through her physical exam, I noted no abnormalities in the heat exam, no sinus tenderness. Her throat was not red or irritated. She reported normal vision, normal hearing. Her eardrums were pearly gray and flat. She had no lymphadenopathy. Her lung sounds were clear to auscultation, and she had clear, regular rate and effort of respiration. Her heart sounds, she had clear S1, S2, no murmurs, rubs, clicks, anything of that nature. GI, she didn't complain of any like nausea, vomiting, diarrhea, anything like that in the subjective history. When I listened to her abdomen, bowel sounds were normal. Abdomen was soft, non-tender. I found no musculoskeletal stiffness, swelling, no problems with range of motion, normal range of motion, active and passive. She had no edema. She had good pulses peripherally and all four extremities. And she was alert and oriented as far as her neurological status. Her memory was good and alert and oriented ×4. So we originally saw her in the clinic on March 28th, which is when she came in complaining of the anxiety and depressive symptoms. And then she re-presented into the clinic on April 1st for a follow-up on the lab work that we did on the 28th. So the lab work that I'm reading to you is from March 28th. So the abnormal values were her sodium was 134, her CO2 was 19, her vitamin D was 19, and all other labs that we tested were within normal levels, including things like we did check her hemoglobin A1C, it was 5.8. We checked her potassium, it was 4.1, chloride, calcium, anion gap, glucose, she was fasting, her glucose was only 82. BUN and creatinine was 16 and 0.51. Her AST and ALT were both an 18. Vitamin B was 471. TSH to check for hypothyroidism to account for some of these symptoms. Her TSH was 1.3, so within normal range. She was not anemic. We checked for that as a possibility of the fatigue and such. Her red blood count was 4.37, and then making her hemoglobin 12.1, hematocrit 36.3. Her white count was 3.9 as well. Sorry, I forgot that on a abnormal lab value. So moving on to assessment and differential diagnosis. She already had a diagnosis of depression, ICD code F32A in her chart, as well as a diagnosis of anxiety, F41.9 in her chart. And both of those were evident with her visits, these two visits. The depression was characterized by the low mood, the anhedonia, hypersomnia, and the difficulty concentrating, as well as her subjective and objective findings of her being tearful and all of these findings. And then the anxiety disorder, she did communicate with us that she did not have panic attacks, but that she did have anxious feelings along with the depressive feelings. So along with those, we also diagnosed her with complications of pregnancy, Z87.59, with her history of the 2 premature births. And then we also diagnosed her with obesity class 1, E66.811, with the BMI of 33.1. Which could be contributing to her metabolic profile as well as contributing to her mood. Additionally, so some differential diagnosis. We could also consider that electrolyte imbalance could be the reason for the mood disturbances. The mild hyponatremia as well as the low CO2 could indicate an underlying metabolic disturbance, or the effects of medications, but more than likely it was just due to the CO2 would be due to the hyperventilation of her being anxious about the lab draw and the visit to the clinic in general. Another differential diagnosis would be a vitamin D deficiency. Since her vitamin D level was low, vitamin D is highly correlated with mood and overall health. So this could be a possibility for her feelings of depressive symptoms. And then she also had the mild leukopenia, the slightly low WBC. So we should continue to trend that, and then also check to make sure that she doesn't have any signs of like an infection or any thing like bone marrow complications or anything like that through continued labs and through monitoring other symptoms as well. Our plan, so pharmacologically, we initiated venlafaxine 75 to address her depressive symptoms and her anxiety. We suggested that she stop her sertraline 100 since it didn't appear to be working for her anymore. And then so that we started on March 28th, we also started her on some vitamin D replacement vitamins. And then when she represented back on April 1st for a follow-up on her labs, we did go ahead and offer and start her on semaglutide, 0.25 milligrams to aid in her weight management, to try to help maybe reduce the obesity, and see if that helped with her menorrhagia and any future OBGYN complications. We did refer her to a specialist. We referred her to Dr. May, an OBGYN, to help try to find more specifics on the cause on her premature births. At that follow-up, it was only 5 days later. She'd only been on the meds for 5 days on that April 1st follow-up. But she did report that she felt like her mood was better. It was subjectively better, and objectively, she was less tearful and a little bit less flat in her affect. Plan going forward, she would also need to follow up. We said to follow up 1 week out, and call if she had any unusual symptoms or mood changes or anything. And then after that, more like 4 weeks out, to further evaluate the full effectiveness of the medication. We would want to repeat labs to monitor the sodium, monitor the WBC, as well as checking to make sure we're replacing her vitamin D accurately. We also counseled her on lifestyle changes as far as her weight loss, talking about the semaglutide as a aid, not as a 100% quick fix, talking about things like diet and exercise to help reduce her obesity, as well as help with the pain from her menorrhagia and elevate her mood from the depression. We have educated her on potential side effects of her new medication, as well as the importance of adherence, making sure that she takes the medication at the same time every day so that she maintains constant levels and gives the medication the best opportunity for it to work for her. And we also provided education regarding the importance of follow-up appointments and routine lab monitoring. So my clinical reasoning of this whole case study was the interaction between her abnormal lab values and her psychological symptoms. We used a biophysical model linking the low vitamin D along with the stress that she's been going through with the premature births. So the vitamin D, the biological factors of vitamin D, obesity, the electrolyte imbalances, along with the psychological factors of her history of anxiety and depression, along with the additional stressors of the premature births. And so it really makes for a complicated case. She had stress coming from a lot of different possibilities, but the biophysical model helps us incorporate all of them into a total picture of her mental health and well-being. As a conclusion, I picked this case study because I really felt like it looked at the holisticness of care. We could look at the labs and say, oh, your labs are mostly okay, here's a vitamin D pill, but we did refer her to counseling as well. We referred her to OB to really kind of give her the best options mentally and biologically in her outcomes. Thank you.